And once we talk about it, the cancer that gets exposed to mutations will develop resistant mechanisms. And that's what we see in oligoprogression. I'm going to talk quickly mostly about EGFR, mutant non-small cell lung cancer, because it's the one that we have seen more from the disease that transform. So what happens? We have the gene mutated, right? You block that gene mutation with the TKI or the drug. Well, the cancer finds a mechanism to survive outside of the original pathway. And sometimes that makes the cancer go from adenocarcinoma, which is the most common type of lung cancer, to small cell, which is a different type of lung cancer. This is a rare phenomenon, but as we continue to see our patients living longer and longer in targeted therapy, we're seeing more. This is some of the data that comes from NGH. And depends on who you read, the frequency of transformation of adenocarcinoma to a squamous cell or small cell can range from 4 to 15%. And why is this important? Because the disease treatment is very different. So usually these patients don't have oligoprogression. They have like a frank progression. The disease is just growing faster than was growing before. But the only way to really show if this is a different type of cancer is to a tissue biopsy. It means we have to go to the site that is growing significantly and take a biopsy to understand. I'm a big proponent that when patients have a lot of disease progression, to do a repeat biopsy, because this allows to understand how is the cancer finding a way around? How is the cancer develop the resistant mechanisms? So the number 2 thing we talk about oligoprogression is if the disease is not behaving like it used to behave, that may be a clue that we are dealing with a transformation. This is a rare phenomenon, but it cannot be missed. So in the case scenario in which the patient has only a few disease progression, here's where we are. Oligoprogression. So we treat it with local therapy, radiation, surgery, ablation, or any other therapy, and the patient remains in the pill or the target therapy they were on. And we're learning more and more about oligoprogression. This comes from a news article, actually, and that talks about how we can use radiation in patients that have disease progression certain size to try to get control of the disease for a little bit longer, and our patients remain in targeted therapy for a little bit longer. Important to mention is that treating those disease progression doesn't mean that the cancer is cured. It just means that we're buying time in the current therapy. There are certain cases in which patients get radiation to the remaining sites, but that's very different. That's oligometastatic disease. These are patients that are already in targeted therapy. The cancer grows on the targeted therapy. And as I'm coming to the end of my presentation, I want to use the example that I use for my patients that I think has been very successful. And as somebody who lived in the Midwest for 6 years and used to have a yard, these guys, the dandelions, are like a headache in the spring. So oligoprogression is like pulling a dandelion, right? You get your little thing and you pull that dandelion. You know it's going to come back, but it gives you a little peace of mind to know that you pull it and at least you're not seeing it. And as you know, dandelions pollinate quite easily. So there is some data that suggests that treating that clone or treating that disease that's growing may provide more control and longer benefits. So oligoprogression disease is like pulling a dandelion. You pull the dandelion with radiation, surgery, ablation. The cancer is no cure. Your jar is not completely free of dandelions, but you get some time in your current therapy. The dandelion may come back later. We don't know exactly when, but we will be prepared to find other options. And as I finish the presentation, we need to continue to have better and improve the communications with our patients. As I said before, many times the disease oligoprogression talks to my patients before it talks to me, meaning they have new symptoms, they have new concerns, and all those little things need to be listened to and addressed. So we are able to control the disease early on when it's growing instead of waiting to get a wide progression, and then these local therapies are not an option.